Okay, so we can start. So the first case is called hit and miss. So I hope you will follow. So this is a patient. No, I was not involved in his care, but it was a colleague of mine who looked after him. So he's a 75-year-old gentleman who had a history of ischemic heart disease. In fact, he was a medical practitioner. He had a coronary artery bypass graft on the 2nd of November, that's last month. And he had a background history of high blood pressure and high cholesterol, for which he was taking a statin. Now, following his major surgery, he presented with acute onset chest pain. So I suppose when you see a patient following CABG or coronary artery bypass graft surgery who gets discharged well and then comes back with acute chest pain, there are a number of things that would go through one's mind. But on clinical examination, this patient was tachypneic, respiratory rate of about 30, he was in distress, and he was hypoxic. And clearly, I think we can go through all the possibilities, but I'd like to know what you would think of. So, when you do have a bypass graft, I mean, many things can go wrong. So he could have developed a pulmonary embolism, because that would be the commonest consideration. He could have developed sepsis, so he could have got a pneumonia, he could have had infection of the surgical wound, he could have had a bleed, so the graft may have ruptured, so he could have bled into the pleural space. They would not get tamponade because at bypass graft surgery, they cut the pericardium, so there's very little chance of them developing a cardiac tamponade. And as I mentioned, pulmonary embolism would be the first thing you would think of. Is there anything else anyone would consider as a possibility of a patient who's had coronary artery bypass graft and comes in with respiratory distress? Any other possibilities? Yuva is not here, he was going to do. What about arrhythmia like atrial fibrillation or ventricular arrhythmias? Because, I mean, obviously he's had major surgery to the heart. But, so on review, so this is his scout chest radiograph, which shows the sternal wires. His clinical examination did not show any arrhythmia. Okay, so what else would you investigate him for? Now, when you screen for pulmonary embolism, what screening test do you usually use here? Do you do the D-dimer? So if a patient comes in de novo with a suspected pulmonary embolism, the clinical algorithm is to do the D-dimer, and if that's positive, then you can proceed either with a VQ scan, a ventilation perfusion scan, or the gold standard, which is a CT pulmonary angiogram, right? But you can see from the plain chest X-ray, there's no hemothorax, so there's no pleural effusion or bleed to consider that. Even though this is a BSU film, there is no cardiomegaly. Agreed? So what else would you want to do? So would the D-dimer be of value here? Because the patient is about 1 week post-surgery, so it's going to be high, so it's of no discriminatory value. So what would be the next test one would do for this patient? Anyone? Because his white cell count was normal. His inflammatory markers, the procalcitonin was normal. His hemoglobin was normal.
He had his CT scan before the surgery?
No, he did not. He was a lifetime non-smoker. What are you thinking of?
He was doing a CT scan.
Looking for what? So in other words, you presented with this patient, comes in with acute respiratory distress, 1 week post coronary artery bypass graft surgery.
Because
the D-dimer won't be alpha because he just had surgery a week ago, major surgery. So it's going to be high, so it has no discriminatory value in this setting. Oh, Well, what other tests would you do? Are there any other possibilities? Okay, so we proceeded straight, well not we, the surgeon actually admitted this patient. He did a pulmonary, CT pulmonary angiogram, and you can see this patient had subacute massive pulmonary emboli. I chose one of the cuts on the CT scan to show the large embolus in the branch of the right pulmonary artery, but there were also major emboli on the left side. So clearly this patient developed a pulmonary embolism post-bypass grafting, which is not surprising. Would you agree? What would the next question be? So if you look at, okay, we'll come back to that. Any thoughts?
You have an embolism in the pulmonary artery.
Yes. So that explains his clinical presentation. He's hypoxic, tachypneic, he needed to be ventilated, he was intubated and ventilated because he became extremely distressed. Okay, and when you looked at his clinical history, they went through, he was in obvious right heart failure. He was then, the surgeon put him on a heparin infusion. His platelet count was 28,000 and a DIC was considered, we know that's a consumptive coagulopathy, but that was negative. But remember that the FDP would be high, but I said the white cell count was normal, so the hematologist thought that the DIC was unlikely. And the patient progressively worsened and he died 3 days later. Again, not surprising because this patient had a subacute massive pulmonary embolism in the setting of somebody who just had major surgery. So the question you need to ask yourself, well then, okay, let me just quickly go through this slide. So this is the recommendation from the American College of Chest Physicians on what should happen to patients after they discharged following coronary artery bypass grafting. So about 10% of patients would develop thromboembolic disease. Usually it's in the lower limbs, and a small percentage of them would then embolize. So what precautions does the surgeon take to prevent that? So intraoperatively these patients are given heparin, but that's to facilitate the bypass grafting. The patient is put on a heart-lung machine, so they get huge volumes of, huge amounts of heparin during the surgery. Right. At the time of surgery and immediately post-op, the patients are given compression stockings, and if the patient is low risk, they continue with heparin 5,000 units twice daily. If they're high risk, then they give it 3 times a day, or they give low molecular weight heparin. And then the next step is when the patient is discharged following bypass grafting, what precautions can they take to prevent pulmonary thromboembolic disease? So the current guideline is that they do not use prophylactic anticoagulants routinely. So the patients are not discharged on those new oral anticoagulants. They discharge when they are mobilizing. They may or may not be required to use pressure stockings at home. And the consensus is that that's adequate. Okay? And I think it's probably safe for the majority of patients. So my question to you is, why did this patient get a pulmonary embolism? So as I mentioned, that thromboembolic disease is a common post-operative complication irrespective of what kind of surgery anybody has. Now there is some belief that when the patient is discharged on an antiplatelet agent such as aspirin or clopidogrel, it may protect against venous thrombosis, but that's not very clear. It certainly helps with preventing graft occlusion and arterial thrombosis. It's not clear whether it is sufficient as a prophylactic measure against venous thromboembolism, but that's routinely done, okay? And in fact, when I spoke to the cardiologist and I looked at the literature, they recommend that only if the patient has atrial fibrillation or they had an end arterectomy done during coronary artery bypass graft surgery, then they would consider giving routine anticoagulants for a period of about 30 days, maybe even longer if atrial fibrillation obviously persists. So when we looked at this patient, the question is, why was the platelet count low? Remember I showed you early on that on admission with acute pulmonary embolism, his platelet count was 28,000. Does that strike a note? Anyone has any idea what happened here? So in the routine clinical practice, we see lots of patients with massive pulmonary embolism post-op. I run an intensive care unit and I see one a week. Some of these patients unfortunately come late and they die. But in each patient you need to investigate the circumstance so that with hindsight you can look back and see, was there a preventable cause or was there an explanation for why that particular patient got a pulmonary embolism. So in summary, this patient is a 75-year-old man, post-coronary artery bypass grafting. A week later develops a massive, subacute massive pulmonary embolism, progressive respiratory failure, right heart failure despite treatment, was given a heparin infusion and the patient died. They were worried about bleeding complications because the platelet count was 28 and it dropped further. So any thoughts? I think the clue was in the title of my presentation. If you want, I'll go back. Does that help? So the patient had heparin-induced thrombocytopenia. What's the significance of that? So when we reviewed the patient's intraoperative and preoperative records, what we found is that there were no intraoperative problems. He made an uneventful recovery and he was discharged well. But when they did a full blood count, when the patient was discharged, the platelet count was noted to be 78,000. And it was about 50% or more of what it was pre-op. So the diagnosis therefore is heparin-induced thrombocytopenia. So what's the significance of that? Does that explain the patient's pulmonary embolism? Has anybody seen such a case? So this was quite important. In fact, it's a lesson to all of us. So when we in fact, in modern clinical practice, coronary artery bypass grafting is done fairly frequently. I'm not sure in Reunion how many a week are having cabbage. Do you know, Yuva? Maybe 1 or 2 a week?
Yeah.
16 something. So it's a huge number. In fact, in South Africa, I mean, every day in one hospital, somebody is having a cabbage procedure done because coronary artery disease is so common. And all the patients intraoperatively get heparin. And therefore, we need to be acutely aware of the problem of heparin-induced thrombocytopenia. So how would thrombocytopenia predispose a patient to getting pulmonary embolism? So it's a life-threatening complication of exposure to heparin in about 5% of patients who receive heparin. It is irrespective of the dose of heparin or how it was given, whether it was given intravenously or whether it was given subcutaneously. Okay? And also not related to the type of heparin you get, whether it's fractionated or unfractionated, such as Clexane. Okay? And the mortality is 20%. So 1 in 5 patients who develop heparin-induced thrombocytopenia will die. Why do they die? One of the major complications is venous or arterial thrombosis. So the next question is, why would somebody who gets thrombocytopenia paradoxically get thrombosis? And the answer lies in the mechanism of the heparin-induced thrombocytopenia. So what happens is, in this 5% of patients who get this condition, they develop platelet factor 4 antibodies after exposure to heparin. When that happens, these IgG antibodies complex with the platelets. Okay? these immune complexes then attach to the Fc receptor and then are removed by the reticular endothelial system such as the spleen, and the patients then get thrombocytopenia. So the thrombocytopenia per se is a form of immune thrombocytopenia, but in itself it's of no consequence. But what happens is when these platelet antibodies attach to the endothelium and Fc receptors, it activates the platelets. When it activates the platelets, it then causes platelet aggregation and thrombosis. And the thrombosis then leads to the complications. So when you see this patient, they may get gangrene, they may get strokes, they may get coronary artery events, and they may get thromboembolic disease in the venous circulation. Very important to consider. But what is worse is that if this condition is not recognized, then you may contribute to worsening. So my question to you is, how did the treatment that this patient received actually contribute to his death? Anybody? So if you are unaware of this condition and you give heparin or heparin-related products such as low molecular weight heparin, you will aggravate the platelet aggregation and thrombosis, and this condition will get worse. So what actually happened in this patient is when this patient was admitted with a pulmonary embolism, we should have recognized that his platelet count was low and then made a diagnosis of heparin-induced thrombocytopenia, and heparin analogs are totally contraindicated because what it would do is it would drive the process, and what actually probably happened is that this patient's pulmonary embolism got worse because you fed the problem with more heparin. So the more heparin you give, the more antibody formation you get, the worse thrombocytopenia, but paradoxically you get thrombosis because you're getting activation of the platelets which adhere to the endothelium and you propagate the thrombosis. So in fact, in our intention to treat this patient, we actually made matters worse by not thinking of the problem. Okay? So how do you now consider this problem? So in the guidelines, they suggest that there are 2, maybe 3 types of heparin-induced thrombocytopenia. So the type 1, which is a clinical type where you get a mild drop in the platelet count. Usually these patients who are exposed to heparin, within 5 to 10 days after exposure would get a drop in the platelet count, and the platelet count is usually above 100,000 and it has no clinical significance. Okay, and again, the mechanism there is not due to the heparin-induced antibody, but due to the heparin causing platelet aggregation. But the type 2 which is the one that is significant because it is due to platelet antibodies, and the platelet count is usually lower than 100,000. So when you see a patient who's received heparin and gets a drop in the platelet count below 100,000, you need to consider this condition. And the simple clinical lesson is not to give heparin or low molecular weight heparin to these patients. Okay? Then you get the subclinical type where the patient has developed heparin-induced thrombocytopenia, and if you are able to measure the antibodies, in fact there is an assay to actually measure the platelet factor 4 antibodies, but it's not routinely available. But you need to recognize these patients because if you give them heparin again, they can get severe thrombocytopenia and then also paradoxically develop an increased risk for thrombotic events, whether it is arterial or venous. Now this patient in question was protected from arterial thrombosis because the patient was on antiplatelet agents. And again it goes to show that the antiplatelet agents are effective in preventing arterial thrombosis, not venous thrombosis. So it's hard to predict who will get it, but if you summarize this case and you look with hindsight, when the patient developed a platelet count of 78,000 on discharge or post-op, they should have recognized this entity and ensured that this patient was protected from thromboembolic disease by giving them a new oral anticoagulant that is non-heparin. So we've got many agents that we can use. Okay, and certainly what should not have happened patient should not have received heparin as form of his treatment for his subacute massive pulmonary embolism, which in fact I believe was the cause of his death. He could have been saved. Okay. So who is at particular risk for getting heparin-induced thrombocytopenia? So it's usually surgical patients, but medical patients may get it. As I indicated, it does not matter what dose or how you received the heparin. It also does not matter whether you received unfractionated heparin or low molecular weight heparin. And older patients are at greater risk than younger patients. So when you look at this patient, he was 75 years old. He was obviously old in terms of the risk category. And he had a major surgical intervention. And worse still, he was exposed to heparin and then re-exposed when he presented with the pulmonary embolism. Okay, and remember that it presents typically 5 to 10 days after heparin exposure. So just to remind you again, you should suspect it when the platelet count is less than 150,000 or it drops to 50% of the pre-heparin exposure platelet count. You get venous arterial thrombosis post-heparin exposure, and one of the early evidences which this patient didn't have, but you may get skin necrosis at the site of the heparin injection. So if you give the heparin subcut and you see skin necrosis, consider heparin-induced thrombocytopenia. And the other way you may suspect it is when the patient receives heparin and they develop a systemic reaction, which may be a combination of fever, chills, tachycardia, maybe an anaphylactic reaction or shortness of breath. Shortly after exposure to the heparin, then you should suspect that this patient has developed HIT or heparin-induced thrombocytopenia. Okay. Now, the ACCP, the American College of Chest Physicians, proposes some guidelines, and they have a scoring system to diagnose heparin-induced thrombocytopenia. It's called the 4 T's, and since I have time, I'm going to go through it. So the first thing is you need to identify a thrombocytopenia. So if the platelet count drops to more than 50% of its pre-heparin level and it's above 20,000, then you allocate 2 points. If it is between 30 to 50%, then you give 1 point, and if it falls to below 30%, then you give no points. Okay? Then the timing of the platelet count, if it drops between day 5 and day 10, then you give 2 points. Consistent with fall at 5 to 10 days but unclear, then you give 1 point, and if the platelet count falls within 4 days without recent exposure, then no points are given. Okay? Thrombosis, if you have confirmed new thrombosis, skin necrosis, or acute systemic reaction, then you, after intravenous unfractionated heparin, you give 2 points. Progressive or recurrent thrombosis, non-necrotizing skin lesion or suspected thrombosis, 1 point, and obviously if you have no thrombotic event, 0 points. If you have no other cause for thrombocytopenia, you give 2 points, 1 point if it's possible, and no points if it is definite. I think that, yeah. So the interpretation, a point value for each of the categories is determined, and if you have 0 to 3 points, it's low probability. If it is 4 to 5 points, intermediate probability, and 6 to 8 points, it's high probability. This is from the American College of Chest Physicians guidelines. Okay. So if you want to just summarize the approach to a patient, so when you have a patient in the appropriate clinical setting with thrombocytopenia and you suspect it's due to heparin, step 1, stop all forms of heparin. Okay. Confirm the diagnosis, and again, if you can measure the antibodies, it's not routinely available in our setting, but it's available in certain settings, and I believe that it's available in the US. I don't know about Europe and the UK. If the patient needs ongoing anticoagulation, like the patient I presented, then you have to use non-heparin related anti-thrombotic agents. Okay, so it's there's a whole lot of agents that we have, and so you don't need to. I mean, in modern practice now we have options other than heparin. Okay, so if the patient's thrombocytopenia is not related to heparin, then clearly we should look for other causes for the thrombocytopenia. The reason I'm presenting this case is because we see a lot of pulmonary thromboembolic disease in our post-operative patients, and we don't look for this. And I think there are many features that present to us that should make us suspect this condition. And certainly, if you're aware that the patient received heparin or low molecular weight heparin in the recent past, and the platelet count is low, you should suspect this condition because our very treatment may actually aggravate the problem. Thank you. So my question to you, how many of you have seen this condition before? And what is surprising is, at the time this patient was presented, I had another patient in my hospital who had surgery, a coronary artery bypass surgery, and he lost a lot of blood during the surgery, and he was given a blood, it's about 5 units of blood intraoperatively. And he developed transfusion-related acute lung injury, had respiratory distress, he developed pulmonary infiltrate, and that settled. But shortly after that, this patient developed gangrene of his toes. And we actually went and the surgeon actually did an angiogram and found that he had he had thrombosis of the small arteries in the leg, and said that it was not amenable to surgical treatment, and suggested that maybe we should give the patient an intravascular thrombolysis. And what happened there was, the surgeon said that he was afraid to do that because the patient's platelet count was too low. So when we reviewed the case and the vascular surgeon's report, we went back and investigated. In fact, this patient had exactly the same scenario. When we looked at the platelet count pre-op, it was about 250,000 odd. Post-op, it was like around 100,000. And then at the time the angiogram was done, his platelet count was 35,000. So clearly all the signs were there. When I saw the patient, I had made the diagnosis of transfusion-related acute lung injury, which was correct. But we had missed the observation that this patient had heparin-induced thrombocytopenia. And in fact, when the patient was in hospital following the transfusion-related acute lung injury, he was on low molecular weight heparin prophylaxis. So we actually aggravated the problem and in all likelihood caused his arterial thrombosis. And this patient was receiving antiplatelet agents. So for us, certainly practicing it was a revelation, and now we are quite aware of this problem. And in fact, when you scan the literature, it occurs in 5% of patients who receive heparin, and obviously 20% of them will die if you don't recognize it.
Thank you very much, Professor Lalloo, for this highly documented case of heparin-induced thrombocytopenia. Any questions from the audience?
So this sounds very common.
Yeah,
I mean, you have 2 cases in
1 month.
weeks. In 1 month. So how common is it?
According to the literature, the guideline, well, the consensus statement of the American College of Chest Physicians, in fact, if you go to the chest journal and just search for heparin-induced thrombocytopenia, there's a whole guideline written and they state it's 5%. So the heparin-induced thrombocytopenia occurs in 5%. Obviously, a small proportion of that develop those complications, and of whom many will die because I think it's unrecognized. And I must say, we are aware of the entity, but we weren't routinely looking for it.
And is it with full heparin anticoagulation or subcutaneous?
No, as they said, it can occur with exposure to any dose and any route of administration of heparin or heparin analogs. Not analogs, heparin, any heparin, whether it's unfractionated or purified or low molecular weight heparin.
Any other question? No question? Thank you very much, Professor. Alors, nous avions d'autres participants, malheureusement. Ils ont été bloqués pour l'instant, puisque nous avions un cas du docteur Allison, professeur Allison, le point sur la rage à Madagascar. Malheureusement, il n'a pas pu être là. un cas de mélioïdose aussi du CHU de Majanga. Pour l'instant, nous ne savons pas s'ils vont avoir le visa, parce qu'il y a peut-être 2 qui pourront venir, et peut-être demain ils pourront présenter si on a de la place. Le docteur Al-Busaïdi de Oman non plus n'a pas pu avoir de visa, donc ne sera pas là. Nous clôturons donc cette session sur les cas cliniques. Je demandais de passer à côté pour la pause café. On verra avec le président. Est-ce que Rada, on commence à 16h comme prévu. Je pense qu'il faut maintenir le programme comme prévu. Nous clôturons donc cette session et nous passons à côté pour une pause café. Merci. Merci beaucoup.
Voilà, donc alors.